Welcome, Dr. Jad.
Thank you. Assalamu alaikum. أسعد الله مساكم. First of all, I would like to thank the organized committee for inviting me to speak today. And it's my pleasure to present in front of my program director during residency, Dr. Aida, and my senior colleague. Actually, they asked me to present when to call GI service or the team. I love it and I like it because on Thursday I will bring only one slide, no need to call GI, and you can use AI instead. Nothing to disclose. Actually, since the audience is, I prepared my presentation for non-GI people, and the majority of the audience are resident. So I only choose these because, unfortunately, you can call GI for a lot of things in acute time. But these, because the time is matter, these are very important. And believe me, any GI specialist doesn't like to call us for these topics of the patient. We will talk about foreign body, we will talk about pediatric acute liver failure, and other GI bleeding. For the time, we don't have only 20 minutes, so we'll focus on the top two. The nightmare for the GI button battery. It's a significant health risk for the pediatric population, unfortunately increasing number of the cases worldwide. Sevenfold increase in relative risk of severe morbidity due to bottom battery last 2 decades. Unfortunately, it's life-threatening condition and can cause severe complication and can be fatal. Epidemiology worldwide, it's 7 to 25% of foreign body bottom battery. Most the children is below 6 years, and with the peak of 1 year of age, which also when the highest risk of complication occurs. It's unfortunately more likely to be unwitnessed, which resulting in delayed diagnosis, and you need a high index suspicion in young children. How about in Saudi? There's a study conducted in MCH Al Hassan from 2017 to 2021. It's by Dr. Hussein Ghadir. By the way, he will be next year beginning to start the fellowship in GI and supervised with my colleague Dr. Al Hassan and also Dr. Nuh and their team. They reviewed 91 cases of foreign body in MCH under age of 14. The bottom battery are the second most frequently ingested after the coins, and they found 80.9 of pediatric foreign body ingested cases involved the batteries. The majority it's occurred in children aged 1 to 4 years. Unfortunately, the bottom battery associated with high rate of severe complication, especially when the battery become lodged in esophagus. What be behind of pathophysiology and mechanisms of injury? The first one is local pressure necrosis. This is the risk one. The second one, corrosive damage from leakage of battery content, because it's alkaline content that causing the corrosive damage, and the main cause for the complication is electrolysis. As we can see here, we have negative pole, anode, and the most dangerous one, and cathode is the positive pole. After attach or contact the esophageal tissue, the electrical current is generated, which resulting in oxide ion formation, which lead to liquefactive necrosis. The same here. After the esophagus, the bottom battery contact the esophagus esophageal tissue, it causing the electrical current generated, which lead to formation of hydroxide ion, which lead to high pH and lead to the necrosis. As we can see here, in the left one, it's bottom battery after 15 minutes. And the right side is after 2 hours. That means is the matter, the time is measured in case of bottom battery. This is another nice one. A and C, both of them bottom battery, but the difference. A, the negative pole facing the tissue or the meat here, and the B, it's bottom battery, but with the positive pole, and the third one, it's the coins. As we can see, 5 minutes, then 15 minutes, the negative pole start to damage the tissue in 1 hour, and lastly in 4 hours. CV compare the negative pole with the positive pole, severe damage with the negative pole, and with minimal damage in positive pole as well. No damage in case of coins. With the site of impaction of bottom battery, we have 3 segments. In the upper part, it's the most common site, around 70%. And in the middle, which is nightmare for the GI because it's near to aortic arch and can cause fatal and very dangerous complication. It's called aortoesophageal fistula. And the lower part, it's count 10%. Are there any factors for the severity injury? Yes. If the size of bottom battery more than 20 millimeter, it causes more damage. Age less than 6 is high risk for severe injury. Also the type, lithium one, is more causing the severe damage as compared with the other. Site of impaction, as we see in the previous slide. Duration is the most factor that affect the patient. Longer duration is more severe injured. Voltage, yes. High voltage, high damage as well. Recognition in clinical presentation is critical because we have narrow window around 2 hours. Unfortunately, the most complication occur after unwitnessed, and that's why causing delay diagnosis due to variable and non-specific symptoms. If witnessed, it's easy. There is respiratory and GI symptoms, but if unwitnessed, it's not that easy. Can present with hematemesis, hemoptysis, melena, abdomen pain, weight loss, and respiratory. And these symptoms share with other system and can delay the diagnosis. For the, I brought this one, very important. If we have foreign body, regardless what is it, we have to ask ourselves 2 things. Is it an esophagus or a trach? Is it bottom battery or coins? How to answer the first one? simple principle. Always GI team facing the problem. That if you see the AP view and the foreign body facing you, this is in esophagus. The second question, how to differentiate. You can see the right one, the coins, and the left one is bottom battery. We have double ring to compare with the coins. Why this is very important? Sometimes the family doesn't know either bottom battery or the coins. You have to do X-ray and you have to see the double rings. The same here, double rings is obvious, and this is bottom battery. Complication, as we see previous, the mucosal damage can occur within 2 hours from the ingestion of the bottom battery, and perforation are usually diagnosed within 2 days, but the fistula, it's presenting up to 4 weeks post removal. And this is very important that any bottom battery removal, you have to give him longer follow-up to make sure there is no complication. Because the other complication, it can take weeks to months to develop, such as esophageal strictures and laryngeal nerve injury. The positive things in bottom battery, if past the esophagus, and even during the overnight, it passed the esophagus, that means we are relaxed. Why? Because the complication here less. If it's occur in the stomach, the complication around 7%. In small intestine, it's 1.3. I will not speak about all complications for the bottom battery. I only highlight the aortoesophageal fistula because it's rare, but fatal one. You have to consider it and keep it in your mind always if you have bottom battery. It's because of, in fact, the bottom battery in the middle of esophagus, which adhere to the aortic arch, and stay longer and can cause the fistula. Here the picture from the endoscopy. And this is very important one. We studied the 35 cases of aortoesophageal fistula, and see the majority here, the present with hematemesis. So this is the very important. If you have hematemesis, upper GI bleeding, in any child, you have to think about foreign body, especially bottom battery. Not always all aortoesophageal fistula can present with upper GI bleeding. It can present with the other, like vomiting, abdomen pain, and etc. Here's the a case I faced during my career, just a few months ago, with the 4-year child, Down syndrome. He take the bottom battery and impacted in lower esophagus. As you can see here, the lower esophagus is really deeply damaged, grade 2B, and alhamdulillah successfully remove it. And we keep follow up the patient till now. There's no complication. That's why the time is really a matter in such cases. I will not go deeply, but this is nice algorithm regarding the anyhow, if you have bottom battery, you have to do 2 few, lateral and AB few. In esophagus, more than 12 hours, don't do the endoscopy. You have to do the CT and call our colleague at the pediatric surgery, because to see any complication, especially the fistula. If you remove it, maybe the patient is died on the table. If no, less than 12 hours, you do the endoscopy. During waiting for the endoscopy, ask the family or ask the physician in the house to give honey or saccharofate. Honestly, any my family or any colleague call me regardless the foreign body, what is it? I ask him just give honey and go to ER immediately. Why? We will see in the next slide. Beyond the esophagus, simple principle, beyond the stomach, this is for our colleague in pediatric surgery. In the stomach, it's less more than 12 hours, you will remove it. Less than 12 hours, here the debate. This guideline from European and different from the North America. The European one, they said if asymptomatic, you can discharge the patient, give the instruction, and bring him after 1 and 2 weeks, and if not passed, to do endoscopy. The North American, it depends on the age. If less than 5 of age and more than the size of bottom battery more than 20, you have to remove it immediately over the night. If more than 5 years and the bottom battery less than 20, you can discharge him and bring him after 1 week. Why honey and saccharofate? To reduce electrolysis by coating the battery. Also neutralizing the hydroxide ion, as we said before, because both of them are weak acid. The diagnosis, the dose is easy, 10 ml every 10 minutes for maximum 6 doses. This is the message. If you don't know sharp bottom battery coins, just ask the family. If anyone call you to give honey regardless and go immediately to ER. It's a contraindication if more than 12 or any suspected complication. It's with more, if stay more than 12, you will suspect the complication or allergy or less than 1 year. How about the other foreign body? Coins, the most common, easy one, and lighter one, and the heavy one to call me for the coins to remove it. If in esophagus, principle, anything in esophagus, regardless what is it, you have to remove it. But the time is debate. You remove it now or you can wait till tomorrow. If symptomatic, anything in GI, stomach, esophagus, symptomatic, remove it immediately over the night. If asymptomatic, you can wait till tomorrow to remove it. In gastric, again, symptomatic, you will remove it. Asymptomatic, you can wait up to 4 weeks. Beyond stomach, this is for our colleague, pediatric surgery. Food impaction, the same. If not, tolerate the secretion, you have to remove it over the night. If tolerate and is still impacted in the esophagus, you will remove it within 24 hours. Here, very important things. If you remove it, regardless what grossly, you have to take the biopsy because you will look for the pathology like xenophilic esophagitis. Sharp object, regardless the symptoms, regardless the location, you have to remove it over the night. Magnet, single magnet, as a coins, relax, no need to remove it, unless the patient has symptoms. Multiple magnet, regardless symptoms, you have to remove it as quick as you can. This summarized, you can see emergency and urgency. Emergency in case of asymptomatic or bottom battery or sharp object. Others, urgency within 12 and 24 hours. The second topic with pediatric acute liver failure. In the case, a 3-day-old baby boy came with circumcision. They took the coagulation profile, and with CBC, coagulation profile INR came high, 1.8. Then they ordered the liver function came normal. Is the patient has acute liver failure? Another case, no case of chronic liver disease with mild elevated ALT and AST and high INR around 2. The same question. Is that acute liver failure? The third one.
2 minutes, please.
Okay. The third scenario, 3 years old, admitted due to acute gastroenteritis with normal AST and ALT, and the NR is high, 2.2. Is he in liver failure? To answer this scenario, you have to know the definition. First, acute onset of liver disease without evidence of chronic liver failure, plus biochemical evidence of severe liver failure, plus coagulopathy. This is very important thing. High NR does not mean liver failure. You have to give vitamin K, wait 4 to 6 hours, repeat it. If not corrected, you have to think about liver failure. If corrected, it's not a liver failure. Especially if INR more than 1.5 with evidence of hepatic encephalopathy, or more than 2 without encephalopathy. All these, if met, this is acute liver failure. I will not go deep in details in etiology, just I want to deliver one message. Half of the cases, the etiology is N. Either in up to 3 is 45, and more than 3 is 46. The time is very important because pediatric acute liver failure is rapid and dynamic and unpredictable. And as we can see in this picture, the interval between the presentation and clinical outcome, such as liver transplant, death, and spontaneous recovery, can be short, a few hours or delay for some children. The median time to death in pediatric acute liver failure is 6 days. That's why it's very important to decide to transfer the patient in liver transplant center, because the timely transplantation is critical to minimize the complication and improve the survival rate. If the survival rate after transplantation is very good, in first year and in 10 years, 73. I will not go with the more diagnostic factors for the time issue. I will just, this score is help the GI when to transfer and when to keep the patient under observation in the same hospital. It's called BUILD score. A disease severity index that estimates pediatric patient short-term mortality risk within 3 months without liver transplant, and used to determine the medical urgency for child less than 12. And here is the score. If less than 10, just relax, just more observation is very low risk for death without transplant. If the score is higher, that means the patient is very sick child and need transplant soon to survive. And the opposite, if low, you can wait and patient because less sick child. Lastly, in brief, upper GI bleeding. I will not go with the differential diagnosis. Here, 2 classifications: variceal bleeding and non-variceal bleeding, because the management and the prognosis is different. Stable the patient. If he needs blood gift, we try to, as much as we can, control the bleeding by medication, by BBI infusion in case of esophageal varices, extratite, and antibiotics. If not control, we can give
Conclusion, please.
Last two slides. We can use this one in emergency or in endoscopy. Either injection, which is not a good one because the risk of rebleeding again up to 80%, and clipping, and lastly ABC. If we cannot control, our colleague in pediatric surgery can handle the patient, and thank you.